starting the timer, and here is your question.
Yes, ma'am.
Yes, just a second, 20 seconds are left. Right, so if you have read and understood, considering it critical care scenario, kindly tell me, how would you manage this patient now?
I will examine the patient and will manage the patient as per CRISP protocol of surgical patients.
Yes.
I will examine the patient and will order a chest X-ray. Considering that the patient has had I will examine the chest. I will inspect the chest, auscultate the chest, and then will perform a chest X-ray on this patient.
According to the CRISP protocol, what would be the first thing that you'll do? First management.
I will check for his airway.
Okay, very good.
Airway, and then I will check for his breathing, and then check for his pulses and circulation.
Yes.
I will provide two whiteboard IV lines. I will attach oxygen to this patient, provide two whiteboard IV lines, give a fluid bolus,
yes,
and call for help.
Yes.
And then,
how would you assess the breathing of this patient?
I will check for any kind of difficulty in any obstruction in the oral cavity.
What are the things or the factors you look for? You'll look for the respiratory rate, respiratory rhythm, and then
rate and respiratory rhythm,
oxygen saturation, then
oxygen saturation,
then trachea. You look for the trachea with central knot. You look for the chest movement. You look for the use of respiratory muscles and the pattern of respiration. You'll also inspect the skin color and the nail bed. You'll percuss and you'll auscultate. Okay, can you tell me, just suppose, what would be your diagnosis of this patient?
Tension pneumothorax.
All right, how would you assess tension pneumothorax? How would you differentiate it from simple pneumothorax? This is what I want to know.
In tension pneumothorax, on examination, the trachea is displaced away from trachea is displaced away from the site of the tension pneumothorax. The site of the tension pneumothorax is hyperresonant on percussion, and and patient is tachypnic and tachycardic. It's an acute emergency, and emergency intervention should be done in that case.
And hypoxic as well. All right. So, according to the NICE guidelines, how should central line be inserted?
A central line should be inserted under ultrasound guidance, and it's X-ray spot to locate its position, which should be just above, which should be in the superior vena cava, just above the right atrium, and there should be no pneumothorax.
What should be the technique for the insertion of central venous line?
Central venous line should be inserted. It should be inserted just lateral to. It should be inserted at the safety zone, just lateral to the carotid. Just lateral to the carotid artery, in between the two heads of sternocleidomastoid, with a needle at a degree of 30 degrees towards the ipsilateral navel.
And patient's position should be
at the 45 degrees.
Trendelenburg position, head down. Okay, feet up, and yes. All right. Okay. Can you tell me some indications for the insertion of central line?
Centrovenous line should be inserted when many certain medications are given, which cannot be given through the peripheral line, such as inotropic supports and
Yes.
TPN.
Yes.
TPN insertion when we need cardiac monitoring,
Yes.
and when invasive cardiac monitoring, like when we need a CVP pressures, and in case of resuscitation of critically sick patients.
Yes. Good. Can you tell me, can you also tell me what are the complications that you should expect while inserting central venous line?
Expected urgent or immediate complications are pneumothorax or tension pneumothorax, insertion of the catheter in the artery,
Yes.
or if inserted on the left side, there is a risk of damage to there is a risk of chylothorax.
All right. One of the late complication can be central line infection.
Infection.
Yes.
Yes.
Can you
Yes.
please tell me what are the measures that can be taken in order to prevent this infection from happening?
The infection, we should follow the WHO guidelines. The operating surgeon should wash the hands. The
Yes.
area should be painted and draped,
Yes.
and the sterile solution should be left there to dry. It should be done under full aseptic measures.
Yes. All right. Yes.
And and I forgot.
What are the indications when you should advise the removal of central venous line?
When there is it says CVP line should be removed when there is no indication uh, uh, for giving fluids or medication through that channel.
Yes.
For instance, when the patient is resuscitated properly, there is no need for TPN or inotropic support, and the patient is planned to discharge home.
Good. Can you mention few sites where central venous line can be inserted?
It can be inserted in internal jugular vein. It can be
Yes.
inserted in subclavian vein, femoral vein, and thick line.
Very good. Can you please tell me the location of what is the highest point in internal jugular vein where it should be inserted?
And it is just above the clavicle.
The landmark lateral to carotid artery between the two.
Lateral to two heads of the sternocleidomastoid, just above the clavicle.
Yes, on the
lines of mastoid
direction. All right. Okay, good. Can you also tell me, right, once just like this patient, when central line was inserted and all of a sudden patient had had shortness of breath and became hypoxic. So what would you do? What's happening? Where exactly would you insert the needle?
In case of tension pneumothorax,
Yes.
Emergent needle thoracotomy is done in fourth or fifth intercostal space, just anterior to mid-axillary line.
What exactly is the safe triangle?
A safety triangle is formed in the axilla. It is formed in the axilla. Its anterior border is formed by posterior margin of the pectoralis major muscle, and posterior border is formed by anterior margin of the latissimus dorsi. Inferior border is formed by the upper margin of the fifth intercostal space, while the apex opens into the axilla. This is the safety triangle, and this needle inserted just anterior to mid-axillary line.
Okay, last question. All right. Can you tell me what are the things that you'll monitor in order to make sure that central line is functional or it's working right? So what are the yes?
Haplocks should be inserted.
What would you like? What would you be monitoring?
CVP pressure should be maintained
Vitals,
from 9 to
fluid balance.
Okay, vital monitoring.
Fluid balance and right. So these are the things that you'll be looking at. What is the most common infection that occurs when there is possibly central line
Infection by Staph aureus.
Staph.
By Staph aureus.
Okay. Right. Thank you.
Thank you, ma'am.
Can you help me read this image, please?
Yes, ma'am. Ma'am, it shows right-sided tension pneumothorax.
All right, what these arrows are pointing at. When you're reading X-ray, first you have to tell me what exactly you're looking at, what kind of images that is. And then in A, B, C, and D, if you can tell me what all these are when you're reading X-ray.
Okay. A means airway, B is for bony prominences.
Yes.
The C is for cardiac shadow, D is for
Yes.
diaphragm.
Yes.
D is for diaphragm, and
E and F are
E is
equal lung
for
fields.
equal lung fields,
And then
G is for gastric bubble.
Yes, and then H, hilum and mediastinum.
Hilum and mediastinum.
And at the end, there could be T as well, or A as well, artifacts or technical defects. So that could also be like this wire is there. It's not part of the X-ray. It's just the artifact or the extra thing which is attached. So what did you say? These arrows are showing what?
These arrows are showing collapsed lung.
Yes. What else is there? What about the costophrenic angle?
Costophrenic angles are not prominent.
What about the exposure on both sides? What about the cardiomegaly or
this is overexposed film.
Yes.
Overexposed film and with inadequate exposure, the kind of costophrenic angles are not prominent.
Yes, especially on the
especially on the right side and left side also.
Left side. Yes. And what else is there?
It is also a tilted film.
Yes, and the stomach is already
cardiac shadows
in the chest.
Oh, right. Right. I thought it's eventration or rupture.
Yeah.
Then
whatever there is, diaphragmatic rupture or the patient has diaphragmatic hernia, we don't know. So that is already in the chest. So that's one. What about the trachea? Can you see it? Is it central?
It looks like it's central.
And
I can't appreciate it properly.
which one is esophagus and which one is trachea?
I'm sorry, ma'am, I can't appreciate it.
Are there any bony abnormalities or deformities or anything? Not that I can appreciate.
Spine looks deformed.
Curved, yes.
Curved.
Right. So whenever you're describing an X-ray, please mention it properly. First, describe what kind of view that you're looking at. Is it AP view or PA view or of chest? Whatever that is, you have to explain. First mention that and then ABCD. Good. Thank you.
Thank you, ma'am.